Welcome to our oral session this morning, Applied and Field Epidemiology. We're thoroughly excited to invite you to a jam-packed session this morning with a sort of variety both in terms of the pathogen as well as geographical location of the outbreaks. My name is Alex DeVoe. I'm a senior lecturer at the University of Cape Town in the Division of Epidemiology and Biostatistics. But in a former life was very much in the field of field epidemiology as an epidemic intelligence service officer at the CDC, and then as part of the South African Field Epidemiology Training Program at the National Institute for Communicable Diseases. So still very much a passion of mine in terms of applied as well as field epidemiology. My job this morning is going to try to keep us to time, make sure that we give all of our presenters enough time to present their amazing outbreak response. So the way that things will run this morning, we have 5 presenters in the first oral session. And each of the presenters will have 8 minutes to present their work. And then that will be followed by a 15-minute time slot for Q&A. So if you have questions for earlier presenters, please just note them down, and we'll take them at the end of the first 5 presenters this morning. I also have the pleasure of co-moderating with my colleague Seydou Dombia, and who will also introduce himself at the beginning of the second session this morning. So without further ado, it gives me great pleasure to introduce the first speaker this morning. Our first speaker is Bikila Gobena, and he is joining us from Jimma University and from the Ethiopian Field Epidemiology Training Program. And the title of his talk this morning is Dengue Fever Outbreak Investigation in Metahara Town, East Shewa, Oromia, Ethiopia, 2023. Bikila, welcome.
Thank you. Thank you very much. I'm very happy to be the presenter of, especially the oral presenter of this world events. And also, I'm lucky to be the first presenters as the burden of the other behind of me is on me. I'm young enough, no problem. So, I'm Bikila Negesa Gobena from Ethiopia. As let me know some about Ethiopia. Ethiopia is from the few countries of Africans which was not colonized, and also its relations inspired of African countries. This is inspired Nelson Mandela. Nelson Mandela is he got training. He took training from Ethiopia, and also he got political helps from Ethiopia to be to create such like town, Cape Town. I'm happy to come here, really. So directly, when I come to my today's presentation, my presentation is dengue fever or dengue outbreak investigation in Matara Town, Ethiopia. Just dengue fever is, as you know, dengue fever is more, it is arboviral disease. It's more endemic in Ethiopia, especially the eastern parts of Ethiopia. And also this outbreak, the current outbreak is the first outbreak as Ethiopia, especially the regional, Oromia regional, is the huge in the large parts of the country, Ethiopia. Yeah. Yes. So just this is is the problem?
Yeah, I don't think it's. Sorry, I just wanted to check. I don't think the clicker's transitioning. You might need to. Maybe just say next slide. You want to go next slide.
Yeah, okay.
Transition for you.
Okay. So this is my presentation outline, introduction, method, result, and conclusion reference. It's my presentation outline. Next case. Okay, thank you. Just on 25th July, there is a patient present to healthy facilities with signs resembling malaria, but with test is negative for malaria, so that the regional and national team deployed to the area to test and to verify the cases. So almost all 20, among all 11 samples were sent to the regional, the national regional laboratory to verify what the case means. So the overall, the study objective is almost to verify the existence of the dengue and describe the outbreak, identify the risk factors, and also undertake prevention and the control. This is how the meteorology parts, the study setting in study period is almost Matara, and from Ethiopia. Study population is seems like this. This method, sample size, how sample size have been done, sampling technique, and also data collection method is almost as dependent variables is a case of dengue, and independent variables, demographic factors, environmental factors, and geographical factors. This is data analyzed, how data is analyzed. We used, for data collection, we used Kobo data Kobo collection or Kobo toolbox, and also character study participants was binary logistic regression, and also significance of the study was measured. This is a result. Index case was identified on 25th July, which was 12 years female. 11 samples were sent to the regional laboratory, from which 4 of the sample is positive for dengue fever by using RT-PCR with dengue fever serotype 3, and a total of 342 dengue fever or dengue case and 3 deaths with approximately 1% of case fatality rate, and overall attack rate was almost 7.18 among from 100 population. This is attack rate among age group and also sex category. This is almost all age category and sex category. This is a P curve, almost all index cases in 25, and also outbreak is declared on 28, July 28, and also response and action was starting to take on 13th July. So almost all it stopped on September 5, starting from September after September 5, no dengue fever outbreak. This is association, a small, almost all long-lasting insecticide nets. Those people who are not use insecticide nets, especially during daytime, is highly associated with the dengue fever outbreaks, and the presence of water within the containers, and also wearing long sleeves are more protective factors, and also hearing about dengue knowledge is more highly risk. Those who have no any information about dengue fever is almost all about 25 times risks for dengue fever. This is prevention and the control measures, surveillance system, diagnosis and measure management, coordination, risk communication, and also vector. This is conclusion. The study confirmed a dengue fever outbreak in Matara. No using long-lasting net open water storage and lack of information is highly associated with dengue fever, whereas promoting utilization of dengue fever is all what recommended. Thank you very much. Because of shortage of time, this is enough for me. Thank you.
Okay, Okay, thank you, Bekila. And also, sort of being the first speaker does mean we have to work out some of the technical difficulties. But please, as mentioned, if you have any questions, just note them down. We'll take questions at the end of the first 5 presentations. I think there's quite a bit still to unpack in that presentation as well. Okay, so it gives you great pleasure to introduce our next speaker, Saldidi Monteiro, and she is joining us from Universidad de Cabo de Verde. And she will be reporting on the first dengue outbreak recorded in Sao Tome and Principe in 2022. Saldidi, welcome.
Okay, thank you. Okay. Good morning, everyone. I am Celide Monteiro. I'm a student for field epidemiology in the University of Cape Verde. My presentation is about the first dengue outbreak in São Tomé e Príncipe, my country, in 2022. In many African countries, there is a many challenge about the laboratory diagnostic capacity. So the burden of dengue is not well known. Include my country, São Tomé e Príncipe, to this island. Our first outbreak was reported in 2022. The main of our study is us to describe. I'm so sorry, I'm so nervous. English is not my first language. I speak Portuguese. So the main of this study is to describe the social, demographic, and clinical profile of the dengue case report in São Tomé. So this describes study as made including second data from the laboratory of Hospital Aires Muniz. So for this study, we took in consideration following the variables such as sex, symptoms, primary infection, second infection, also start for hospitalization. Now, talk about the result. We can see that in the first week, we don't receive a reporting case, but in the week 14, we receive. When we look to the type of infection, we had a primary infection and secondary infection. 10% of our patients had a second infection. So is that mean that dengue virus circulating in São Tomé before the outbreak reporting? Take age and sex as variable. We can see that women were the most affected and the young people too. Fever and headache are the more symptoms reporting. And in 102 patients reported, one of them required hospitalization. And unfortunately, 3 of them died. Most the case reported as a young people, few them required hospitalization. We see case of second infection. So that means that we have two different dengue serotype, Orwell and Saint-Thomé and Príncipe. So we strongly recommend our authority to improve surveillance and response, also the laboratory diagnostic capacity. So I would like to thank you all the institutes to support this work, my university, University of Cape Verde, my hospital, Hospital Aires Menezes, National Center of Endemic in Saint Tomé, also LCTP. Thank you. I'm so sorry for my English.
Thanks, Saldidi. So for our next talk, we're going to be moving to diphtheria, and we're moving to a local context. So our next speaker is Lavani Naidu, who is from the Western Cape Department of Health, and she will be presenting on the toxigenic diphtheria outbreak at a correctional facility in the Western Cape, October 2023. Thanks, Lavani.
Good morning, everyone. Can you hear me? I am a bit short. So thank you for introducing me. I'll be presenting on toxigenic diphtheria outbreak that occurred last year at our correctional facility in the Western Cape. So basically, diphtheria is a life-threatening bacterial disease. The good news is that it is vaccine preventable. It is caused by toxin-producing strains of Corynebacterium diphtheria, and it can be represented respiratory or cutaneous, as seen in the images on your side. Between the 1st of January and 20th of October 2023, our National Institute of Communicable Diseases confirmed 12 cases of C. diphtheria, of which 5 individuals were found to have toxigenic diphtheria. In 2023, UNICEF reported the national vaccine coverage in South Africa was 81% and 79% respectively. So just to give you a brief background, our suspected diphtheria case was notified on the 28th of October from a district hospital, and the patient had tonsillitis as one of his symptoms. He was also an inmate at a correctional facility. Tonsil swabs were collected on the 30th of October, and then the patient was transferred to a tertiary hospital due to complications of kidney failure and heart block, whilst he was on treatment for diphtheria antitoxin. On the 2nd of November, this date is important because we also instituted public health action on the same day, that we found that the index case tested positive for C. diphtheria on the culture and subsequently positive on the PCR. Unfortunately, the patient demised on the 5th of November. So we investigated a respiratory toxigenic diphtheria case from a correctional facility, and our objectives were to determine the extent of the outbreak, describe the cases by place, person, and time, and also implement control and prevention measures. Our setting and population, as you can see, was at the correctional facility, but not the entire facility. It's the highlighted block you can see in the image. I just blocked out the name, and it is in Section A of the facility. We used case investigation forms, close contact line lists, and also our lab results were vital. That's how we attained our clinical and demographic information, and we specified case definitions as seen in the table on your side, specific to this outbreak. Our data analysis was descriptive, and we calculated mean age, case fatality rate, the attack rate of the positive case, and the contacts included. As you can see, the index case was in contact with 55 inmates. That section of the correctional facility had 1,200 inmates in total. However, the close contacts were only 55 inmates. Of the 55, 8 tested positive after nasal pharyngeal swabs were analyzed. And of the 8 that tested positive, 2 of them were symptomatic with very mild symptoms. So our case fatality rate was 11%. The mean age of the positive cases, including our index case, was 22 years old, and the attack rate was 16%. As you can see on the epi curve, the initial lab-confirmed case of the index case was on the 2nd of November, and then 4 days later we found the close contacts, the 8 close contacts testing positive. Public health action was instituted, and this was a multi-sectoral action that we instituted, and that was on the 2nd of November. And then you'll find that after the 6th, sorry, my eyesight fails me. After the 8th of November, there were no further cases detected, thankfully. So we also stratified the PCR results by age category, and we found that there were 4 PCR positive cases between ages 10 to 19 years. And then from 20 to 29 years of age, there were 4 PCR positive cases. This is just a table of all our close contact. As you can see, I just highlighted the inmates, of which all 8 of them were PCR positive for toxigenic diphtheria. Our public health actions, we had intensified surveillance, clinical management, IPC measures were also part of it, and a vaccine campaign was held at Medium A of the correctional facility. It was important for us to administer antibiotics and diphtheria antitoxin to our at-risk and close contacts, and also to isolate our positive contacts and retest our positive contacts after 14 days after treatment to ensure a true negative result was attained. We also procured additional diphtheria antitoxin if in the event there were more cases. Our vaccination campaign had consisted of 123 staff and 484 inmates that were vaccinated. We also had risk communication as part of our public health response, where National Department of Health and Correctional Services issued press statements. You can see the screenshots on your side. And a provincial circular was provided to our healthcare workers. And also we disseminated situational reports to provide our stakeholders with an update of the outbreaks, including the closeout report. So it was important for us to identify the suspected cases early and provide them with antitoxin based on clinical suspicion. This is prior to getting the lab confirmation. And communication with the ID specialist was also of vital importance. We believe that the rapid identification and follow-up close contacts led to the identification of 8 positive cases. Our targeted vaccine campaign also helped to curb the further spread, and in the province alone, we have about 20 to 40% vaccine coverage. So in this specific outbreak, we did not know the vaccine status of these cases and the close contacts. So therefore, the vaccine campaign assisted us to curb the spread. In conclusion, public health action is important to the suspected diphtheria cases, prompt public health action, that is, and it is critical to curb our transmission, especially in densely populated settings like we had at the correctional facility. Concerted efforts are needed to improve vaccination coverage and provision of booster vaccine to prevent diphtheria, and healthcare workers need to have a heightened index of suspicion and to be vigilant in detection, notification, and investigation of suspected diphtheria cases. I'd like to acknowledge our national and provincial departments as listed below, and also the NICD for their support. Thank you.
Wonderful. Thank you so much, Lavani. Our next speaker is Kennedy Salapako, and Kennedy is from Levi Mwanawasa Medical University in Zambia. And the title of his talk this morning is Anthrax Outbreak in Shisheka District, Western Province of Zambia, December 2023, a matched case control study. Thanks, Kennedy.
Thank you very much, and good morning, everyone. So I'm going to present to you an investigation that was done in western part of Zambia, in the district of Shisheka. So the background to that is that anthrax is a zoonotic disease that is caused by a bacterium, Bacillus anthracis, and over 1,100 cases and 20 deaths were recorded in East and Southern Africa, The disease is endemic in western part of Zambia, and it's affecting both humans and animals. So Sesheke district reported anthrax after over 5 years without reporting any cases. So because of that, we are interested to know what could be the determinants or the factors that are associated with this outbreak, and we have to do an investigation. So our objectives were to assess the exposures contributing to this outbreak, and also to review the surveillance practices for anthrax, and also to make some recommendations in order to deter future outbreaks. This was a matched case control study, and we matched by age and sex. So our study population was the 4 villages that were affected in this district, and our sample size was 16 with 48 controls, and we hoped to achieve a power of 80% at a 95% confidence level, and the ratio was 1 case to 3 controls. We defined our case as any person presenting with the signs and symptoms that were consistent with anthrax, or someone who has been confirmed positive by PCR. Then our controls were any person that has been matched by age and sex and did not have any signs and symptoms that are consistent with anthrax, and is within the neighborhood where we are investigating. So we used a questionnaire that was administered in Kobo to collect exposures and risk factors on cases and controls. We analyzed the data in ARA, and demographic analysis and logistic regressions were performed. We presented this data in matched odd ratios and a 95% confidence level. Our results, we interviewed 13 cases with 39 controls, and we found that all these cases had cutaneous form of anthrax. Samples were collected and confirmed by PCR. Then majority of the cases and controls were male, and these were farmers, 85% of them. Median age was 25.5 years and range 10 years to 66. Coming to surveillance practices, we found that there was poor documentation of surveillance data, and such as line lists which were missing, and notification records were missing. So we also found that there was delayed implementation of control measures. It took 18 days instead of 7 days. That is recommended by 717 metrics. Then these measures were like banning on stock movement and restriction of sales of meat and risk communications and community engagement activities. Coming to bivariant analysis, we found that occupation, most of them were farmers who were affected by this cutaneous anthrax. Then exposure type was contact with bovine carcasses, and also there was an issue of skinning animals that were dying in the area. So the people were skinning them and sharing the meat. Coming to multivariable analysis, we found that contact with the same bovines and also goat carcasses were also involved, and also the skinning of dead animals and contact through eating. However, the implication went on contact with goats and bovines and also skinning of carcasses. Exposure to contracting anthrax, we found that the source of infection was contact with animals, especially bovine and goats, and the skinning was very much associated with contracting the disease, and that males were more affected. And in that area where we are investigating, we found that most of the people who had the animals are men, so most of them had this anthrax. And also the men are the ones who are being engaged in skinning of carcasses and sharing the meat. So this is what we found, and our public health actions, we sensitized the community on the dangers of handling animals that are dying of suspected of an unknown cause. and also through the Department of Veterinary Services, they were able to vaccinate 25,000 cattle out of the 23 that they targeted. So we had the 2,000 extra cattle being vaccinated against anthrax. So our conclusion is that to prevent future outbreaks in this area, there is a need to improve surveillance activities and also improve on documentations. Then control measures should be timely, and also there's need for health education to be continuous and also intensified, especially amongst males farmers. Thank you very much.
Wonderful. Thank you so much, Kennedy. So our final presenter for the session this morning, before we open for questions, is Annapurna Patra, and she is joining us from the government of Odisha. And her talk this morning is titled "How Dead Livestock Led to an Anthrax Outbreak in Block X, Kodapur, Odisha, India 2023, Findings from an Outbreak Investigation." Thank you.
Greeting everyone. I am Dr. Annapurna Patra, IFETP India graduate, presenting the findings from our outbreak investigation of anthrax in our state. So Koraput is a tribal district with 46% of the population being tribal, and the forest covers 40% of the land areas. Agriculture and livestock farming are the main occupations. Block X in Koraput is endemic for anthrax. On 2nd May 2023, 2 case patients with skin lesion were admitted at a public health hospital. This triggered the rapid response team as the diagnosis was suspected to be anthrax. There is no report of anthrax in the last 3 years in the Block X, Koraput. Even a single case of anthrax has to be considered as an outbreak. Hence, we confirmed the outbreak and decided to investigate it. The objective of the investigation is to describe the outbreak by time, place, and person, and to identify its potential risk factor and the sources. The rapid response team identified 11 more cases in the field, and skin swabs were collected from them. 8 out of 11, that is 73%, back positive for anthrax by RT-PCR testing, thereby confirming the diagnosis. We decided to search for more cases actively by door-to-door survey. We defined a suspect case of cutaneous anthrax as the occurrence of painless skin lesion like papules, vesicles, eschar, and a suspect case of GI anthrax as the occurrence of nausea, vomiting, or bloody diarrhea in a residence of Block X between March 15 to May 18, 2023. We described the epidemiology of the cases identified by constructing an epidemiological curve for time, a spot map for place, a attack rate percentage for age and gender. We also describe the probable exposures as percentage. We also conduct interview with the village leaders, case patients, and veterinary department. We identified a total of 26 cases of anthrax, 17 cutaneous and 14 GI cases across the 3 villages in Block X, Koraput. We also identified the death of livestock in Village 1 on 19th April 2023, which was slaughtered and eaten by the villagers of Village 1, 2, and 3. This spot map shows the spread of villages affected by anthrax. The death of the animal and its slaughtering happened in Village 1. The meat was carried to the other villages and consumed. This spot map by village shows the clustering of case patients in Village 1, and isolated case patients in Village 2 and 3. Village 1 was the most affected, with an attack rate of 10%, while the village 2 and 3 was low. This epi curve shows the time distribution of this anthrax outbreak across the 3 villages in Block X of Koraput in 2023. Death and slaughtering of dead livestock happened on 19th April 2023. GI cases peaked on 22 April and subside there after indicating a point source exposure. The cutaneous anthrax cases peaked on 29 April and had a more scattered distribution, possibly due to continued exposure to contaminated material or animals. The attack rate by gender and age represents that males are more affected than the females, with an attack rate of 5%. 40 to 60 years age group were mainly affected. 81% of the cases were having close contact with the livestock. 62% of the case patients were involved in butchering, and all the case patients ate the carcasses. Among the case patients who were involved in butchering, 50% helped in cutting the meat, 46% was washed the meat, and 31% helped in deskinning. From the environmental investigation, we identified that rainy season in April to May usually is associated with anthrax in the livestock, prevented in the previous year by animal vaccination. However, the villagers reported delay in vaccination by the veterinary department, sick livestock which die or slaughtered for meat to ensure some economic return. The soil and bones residues from the burial site came back as positive for Bacillus anthrax by PCR testing. Thus, by bringing in the evidences from descriptive epidemiology and environmental investigation, we hypothesize that the outbreak of anthrax due to the involvement in butchering, handling, or consumption of the carcasses that died on the 19th April 2023. We tested this hypothesis by using an unmatched case control study where the cases was defined as a cutaneous or GI anthrax case patient. An individual from the neighborhood of the case who didn't develop any symptom was taken as control. The ratio of the case to control was 1:4. We estimated the association between the exposure and outcome as odds ratio with its 95 confidence interval by using the logistic regression. After adjusting for age, gender, and other exposure, involvement in washing of carcasses and contact with livestock or other fluids were found to be associated with getting the anthrax infection. To summarize, the rainy months of April to May are associated with history of anthrax spore sprouting. The unvaccinated livestock grazed on this grass and got infected. The livestock which died on 19th April 2023 was butchered in village 1 and the meat was consumed by the village 1, 2 and 3, leading to GI anthrax followed by cutaneous anthrax. We vaccinated the livestock and issued chemoprophylaxis to the community to prevent the spread of infection, and this led to the decline of cases. From the learning, we recommended to continue the supply of chemoprophylaxis to the community and to complete the animal vaccination. In the long term, we must establish a protocol for surveillance of anthrax in livestock with steps to ensure vaccination at the right time. We will also need to set up regulation to avoid butchering of sick animals for meat. And that's how the dead livestock led to an anthrax outbreak in Koraput, Odisha, India. Thank you all. Thank you for your listening patience.
Can you hear me? Okay, perfect, that's on. I wanted to just start by congratulating all of the speakers this morning for showcasing the fantastic work done in all of these different contexts, and also for doing such a good job in terms of keeping to time. And so it happens that we have quite a generous amount of time for questions this morning. So if you could make your way up, I think we've got one mic in this hallway on the left-hand side, and I'm not sure if we have a roving mic as well. Okay, so if you, and we have a roving mic as well, so if you could please just come up as you start to think of questions that you have for our presenters this morning, that would be great. We've got quite a bit of time as well for questions to our presenters. Okay, so as you make your way up, I wanted to start maybe with a question for Lavani. Thank you so much for your presentation this morning, particularly in a kind of relatively unique setting as well within the correctional facility. You mentioned, I think, the vaccine coverage within the Western Cape. Did you have any information in terms of vaccine coverage among the inmates themselves?
Just checking. Oh, it's on. Okay. Yes, so the vaccination status of the inmates at that time was unknown. So that's why we did the vaccination campaign. And we also administered chemoprophylaxis.
Thank you. Hi. And if I could just mention, if you could briefly just state your name and which institution you're presenting before asking your question. Thank you.
Good day. I'm Veerle Msimang. I come from the NICD here in South Africa, in Johannesburg, and I'm an epidemiologist. So my questions is towards the people that talked about anthrax. So I just wanted to know, it was clear from the second talk how many animals were involved. I assume it was one for the gastrointestinal case, and then maybe there were some more for the other ones. I just wanted to know how common is anthrax outbreaks, because you talked about this particular outbreak. How common is the outbreaks of anthrax, and compared to other outbreaks in animal diseases and zoonotic diseases that can spread to humans, and then vaccination seems to be the most cost-effective ways for anthrax. So I just wanted to see how important this disease is compared to other diseases, and how is the uptake of vaccination to prevent it in animals, and then also prevent the spread to humans, of course.
Thanks, Veerle. We can have Kennedy answer first and then pass that on to Annapurna.
Thank you very much for that question. So in Western Province, anthrax is very common, and it occurs almost annually. You find cases in animals. They start in animals, then they spread to human beings. However, this part of the district where we had this anthrax, the cases have not been happening for over 5 years. And vaccinations have been going on in the whole province, and then they are done annually. Every year they do, around June, vaccinations are conducted. So uptake of vaccinations, especially for animals, has been very good, especially in Sesheke. However, in other parts of the province, people are reluctant to have their animals vaccinated despite the vaccine being free. So continuous engagement with the people to have their animals vaccinated is ongoing. Then coming to the number of animals that died in this locality, we had, it started with a goat that died, then we spread to about 4 to 6 bovine animals that also died. Yeah, thank you. I hope I've answered all the questions. Thank you.
Maybe if we could have Annapurna also maybe just describe similar situation in your districts in India. Oh, sorry. So I don't know if the question was really around how common anthrax outbreaks are and other zoonotic diseases,
and a question around vaccination uptake as well.
Thank you, ma'am. Thank you for the question. Actually, the outbreak where it occurs in my state, their particular area, anthrax occurs in repeatedly in every 2 to 3 years gap. But this outbreak occurs in 2023, particularly in that year, the vaccination is a little bit delay, and there are some logistic issue. That's why some of the animals don't get the vaccines on time. And I think that may be the cause of getting anthrax.
Thank you. We'll take the next question.
Thank you. My name is Kafialo Addis at Curtin University in Australia. My first question is to the second presenter, Saldini. You present us that most of the cases of dengue fever were young people. So would you give us more insight why it was common that among those age group, and what kind of public health intervention was done to prevent this? And my second question goes to my friend from Ethiopia, Bagela. Thank you for your nice presentation. Could you give us the current situation of dengue fever in Ethiopia, and how was the geographical distribution looks like during your study? Was that clustered to some area, which may be driven by some factors, environmental factors, and also what was the fatality rate and what public health action was done to stop this outbreak? Thank you.
If you, Anna, pass the mic down, thanks.
Thank you. Unfortunately, I don't know why, because I work in secondary data, but our surveillance department developed education campaign and also work together with the malaria program to fight against the vector of dengue. So, is that?
Thank you very much. The current situation of dengue fever in Ethiopia is highly increased. Previously, it is almost endemic to the eastern part. Now it's almost to the central parts of Ethiopia. It's all distributed. So it's almost all the country's current interventions related to dengue fever is somewhat good, especially the enhancing surveillance system, and also it's insert under surveillance under events of surveillance in the current situation in Ethiopia. So it's almost all geographical distribution is almost to the eastern part of the country, almost all it's endemic, but currently it's coming to the central parts of the country. It's highly increased, even it's double of the previous one.
Thank you. Please go ahead.
Hello. My name is Simon Crouch. I'm a public health physician from Monash Health in Melbourne, which is also in Australia. I had two questions. My first one was for Saldini and may not be able to answer because it was secondary data, as you just mentioned. I was actually interested to know what your thoughts were around women being more impacted in your presentation. And my second question was to Lavani. You've really focused on the inmate context, and I noticed one of your slides you flicked up quite quickly, did touch on some of the other contacts, the other maybe staff, visitors, etc. And I was interested to hear a little bit more about your risk assessment of other contacts and how they were managed. Thank you.
The second infection is more impact because before this outbreak in St. Mary, we think that we don't have dengue circulating in our country. So this study shows us that no, it's not the first time we have a dengue in our country, because we, for diagnosis, we use the quick test, comb test, and we antigen antibody. And for this result of the second fashion, the antigen NS1 and IgG. So it's a proof that it's not a first time this patient gets dengue. So.
Thank you. And the next question was for Lavani.
Thank you for the question, Dr. Crouch. So we had our clinical program coordinator for the area working together with the different hospitals. So the index case was transferred from a primary hospital to a tertiary hospital. And obviously he had been in contact with the EMS division, our ambulance staff, and also other physicians, the wardens, and also there was a security with him because he was an inmate. So they were administered with chemoprophylaxis. They were also swabbed as well to test for diphtheria, and they were also given a booster shot of the diphtheria vaccine as well. Obviously, this happened within the time frame that I did mention. So we had quite a few good people out there working on the ground to assist us. Thank you.
Please go ahead. Thank you.
Thank you. My name is Kabela Sambwa, FETP resident from Zambia. So my question goes to the first presenter from Ethiopia. In your study, you mentioned that you conducted an unmatched case control study. So I'd want to find out what was the ratio of cases to the controls, and what was your sample size, and how did you determine your sample size? And then how did you also select your controls? Thank you.
Thank you. I've presented my presentation because of the time. Sample size is calculated for a match case control by using EP-info version 7.1, and for we use 50 for cases and 1:2 case to ratio. 50 cases and 100 controls is our sampling, sampling in this, our sample size.
Thank you.
Hi, my name is Evelyn Wong. I'm from the Victorian Department of Health in Melbourne, Australia. My question is to Annapurna. I was just wondering, with your case definition, if you had considered inhalation anthrax and the rationale for not including that?
Thank you, ma'am. So, ma'am, just a small request. Can you repeat the question?
I was wondering if you, with your case definition, you had cutaneous and gastrointestinal. I was wondering if you had considered inhalation as well, and why it wasn't included.
Okay. Actually, in that field where the outbreak occurs, we get only the GI anthrax and cutaneous anthrax. There is not a single case of inhalation anthrax.
Good morning. I have two questions. The first one to the Zambia presentation on anthrax. You mentioned that for 5 years you have not seen cases, but you saw it for after the 5 years. So probably you may have aspect of historical data that you might have used. So my question to you is, picking from what we saw from the Indian presentation, was there any preceding events like weather changes that may have contributed to this re-emergence? If that could have been also highlighted, it will give us some highlights into why this recurrence or re-emergence. And while at it, also now also linked to the same for the Indian presentation, the aspect of the event-based surveillance, because that will now be very key, because I noticed from the Indian presentation, you only mentioned the livestock deaths. Were there any confirmation that was done to confirm that the livestock died as a result of anthrax? And I also noticed that there was little involvement of the veterinary department. You only went to interview them. But in terms of interventions, was there any element of approach, that's the One Health approach in terms of the response? Did you involve the other players when it comes to these diseases, the disease outbreak? So just that confirmation and the involvement of the vet in terms of the One Health approach, and is there any event-based surveillance that you'll propose based on what you have seen, such that we use these events to actually try to detect early detection and response? Thank you.
Thank you. Kennedy? Okay, sorry. Annapurna, you can go first, and then Kennedy can go for the first question.
Okay, thank you. Thank you for this question. First of all, we confirmed the animal anthrax. There was a regional lab in that particular district, as it is an endemic district. There the animal samples were collected and tested positive. And for the human samples, in every district of my state, there is a district public health laboratory. The cases were, they are confirmed for anthrax. And after getting the anthrax, along with the veterinary department and health, both together we conduct, there are various ICBCC activities. ICBCC activities and direct contact with the cases, and along with them we visit the, we conducted a survey in that particular village to aware the people about the anthrax, how they proper use the meats, by showing them various demos, how to cook it, and how to properly prepare it and eat, and don't ever consume the dead animal. It may be dead due to any of the cause. Various ICBCC activities we conducted to aware them to avoid this type of animals.
Thank you very much for that question. This outbreak in Sesheke district could be attributed to laxity in vaccination activities, because in Zambia, vaccination of anthrax is a responsibility of a farmer himself, has to buy the vaccine for his animals. So the Department of Livestock, what they do is every year they do conduct campaigns which are free. However, since Sesheke has not been having outbreaks of anthrax, they have not been doing those campaigns in that district. They have been concentrating in other areas where they have been reporting outbreaks. So that's where every year they would do the campaigns. Leaving those areas without an outbreak, that's responsibility to a farmer to buy his or her own vaccine to vaccinate animals. So you find that the farmers start relaxing when they see that in their area they don't have outbreaks. And then the other factor that could have contributed, in that area there is a national park, Sioma Game Park. So the people in that area witnessed some wildlife and domestic animal interface, where the elephants would go from the borders of their park and also interacting with domestic animals. And that could have also contributed in that maybe the vaccination was low, then the animal wildlife also are also coming and interacting with the animals, and hence could also be contributing factors to this outbreak. Thank you.
Thank you both. So we have time for one brief question, if that's okay, and then we'll move to the next set of presenters. Thank you.
Okay, thank you very much. My name is Levi Cheptoyek. I'm representing Jomo Kenyatta University of Agriculture and Technology. My concern is actually to the team of anthrax. I've not heard about issues to do with environmental contamination. What we know is these spores can actually, these spores can stay in the environment for even more than 40 years. And if an animal dies that has anthrax, the spores actually start forming within 4 to 10 hours, and within 48 hours, the spores are completely formed, and they will stay in the soil for all this period of time. But then when these animals, let's say, are disposed and buried, the vegetative forms of the anthrax, the vegetative bacteria will die within 2 to 3 days. So I'm actually wondering what you're doing with regard to containing environmental contamination in your country. Thank you.
Thank you. Maybe we could have Kennedy and then Annapurna.
Thank you, sir. We collect the environmental sample where the dead livestock was buried. From there, we collect the soil samples and the animal samples and tested at our regional lab, which were found positive for anthrax.
Okay, thank you. Kennedy, maybe if you could say a little bit more. I know you mentioned the elephants sort of also in interacting with the environment, but are there aspects of your investigation looking at environmental factors or any other factors in terms of the environment affecting anthrax outbreaks?
Thank you very much for that question. When we are doing this investigation, we took into consideration the One Health approach. So we had a team from veterinary and also wildlife. So it was the whole team and, that was involved. And we also collected the environmental samples, the soil samples, and had them tested. And however, they didn't come out positive, they were negative. However, we continue engaging the farmers and the community so that there's proper disposal of the carcasses once there are mortalities that are recorded. Thank you.
Thank you. So it just leaves me to once again thank the presenters for the first morning session and also to thank the audience for your participation and engaging questions as well. Thank you so much.
Where is my... Okay. Okay, let's start. Good morning, everybody. I'm Seydou Doumbia. I'm a medical epidemiologist and honorary dean of the Faculty of Medicine for University of Bamako, University of Science, Technique and Technology. And we also do host the field epidemiology intermediate level in our university as university diploma. And we are also working to start very soon our advanced level in field epidemiology. So I'm happy to co-chair, moderate with Alex. And in this second part of this session, we will have Mark Mateka from Kenya, and we will have also Bakalilu Kejira. Ali is not here, and Olado Yo Awoyale is also here. So let's start, and you already know the rule. So you have 8 minutes of presentation, and then hopefully we'll have more time for discussion. Thank you.
Thank you so much. Good morning, everyone. I'm Mark Mateka from the Kenya Field Epidemiology and Laboratory Training Program. I will take us through an investigation that we did on groundwater contamination by sanitary facilities at close proximity as a potential cause for cholera outbreak in an island in Kenya towards the end of last year. So just generally, cholera is an acute diarrheal infection, usually caused by bacterium Vibrio cholerae, and the mode of infection is through ingestion of contaminated food or water. Onset of symptoms following ingestion is within 2 to 5 hours, and the infection or the disease leads to severe dehydration and death. In terms of management, antibiotics work for the disease with the oral rehydration solution and IV fluids for fluid management. Globally, we have had cholera burden in developing countries, especially with approximately 1.4 billion people at risk. We have witnessed mortalities as well, approximated at about 21,000 to 143,000 deaths worldwide. Sub-Saharan Africa has contributed at least 46% of these deaths, which shows a huge burden within our continent. In Kenya specifically, cholera is an notifiable disease, and we have witnessed outbreaks within every 5 to 7 years, of course due to poor sanitation and hygiene. And in the recent outbreak, which we will discuss today, the outbreak lasted for more than a year, and we witnessed also areas without cases before having cases for over a decade. Our investigation objectives for the outbreak were to determine the actual magnitude of the outbreak, then to assess water sanitation and hygiene practices among the community, that is from the cases within the community, and to identify potential exposure factors for the community, and of course to institute prevention and control measures in the affected areas. Our site of interest was Mokamani and Shell Awards in Lam County, which is an island in Kenya. We were there for a period of 10 days for the investigation as well as intervention. The target population were individuals, all the individuals who are living in the 2 wards. Our working case definition for the suspect case was persons of all ages presenting with watery diarrhea of an acute onset with more than 3 episodes in 24 hours from October 1st all the way to December 2nd, 2023. Our probable case definition was any suspected case with an epidemiological link to a confirmed case, and our confirmed case was any case that has undergone laboratory confirmation for Vibrio cholerae. We were mainly quantitative. We went through all the records. We did follow up we did follow the cases for interviews with a questionnaire that was helpful in data collection. We did active case search within the community. We did a lot of environmental assessment to find out on any areas that can be associated with the outbreak, and of course we had to confirm through laboratory investigation. Our data analysis was basically descriptive. we worked with MS Excel to do proportions and again to do charts. We used KGIS to do maps, spot maps, to be able to present the cases as we did our active case search. Ethical approval, of course, was not necessary, being a public health investigation in response to the outbreak that had happened. So that is a map that shows our area of concern. If you look around here, this is where the island is. It is Lamu. It is surrounded actually by an area that is at high risk, but at that time, we didn't have any cases within the surrounding counties or sub-national administrative units. The area that specifically was affected was actually an island. There was no connection between that island and the mainland, and therefore that was much of interest. An island that is isolated, having cases, and the area surrounding there, which is the mainland, did not have cases at that particular time. So we went down and we were able to establish the actual magnitude. We were able to list a total of 125 within the period that we were there. Case search was done with the interviews reaching up to 78.4% of those line listed. We had follow-ups to their households at 76.5%. We did contacts, and these were cases that were coming from households that had already reported cases at 12.3%, and new cases who were coming from households that had not reported any cases at all at 11.2%. We noted a break in the infection prevention and control for cholera within the area. And of course, we had 3.1 of those cases attributed to a break within the health facilities. We had mortalities going to 4, that is with a case fatality rate of 4.1%. And these were basically males at 75%. And this was more attributed to poor health-seeking behavior. Actually, one of the patients died at reception at the hospital. 2 were community deaths. Socio-demographics, females were more affected at 56.1%. The age group between 6 to 14 was more affected at 23%. And 2 years and below came in with 12.2%. Then in terms of distribution location, Mokomani ward was more affected at 3.4 attack rate parts per 1,000, as well as Shella ward at 0.7 per 1,000 population. That is the epic curve of what was happening. We noted there was high rainfall late in October before the onset of the disease or the onset of the outbreak. And although confirmation came somewhere around here, from our active surveillance, we were able to pick cases way before that had onset as early as late October. Actually, one of them being a mortality, and this is a person who died while they were being received at the facility. Then we had cases piling up from our active case search and follow-up. And you can see we have 3 peaks at around 20th of November, around 22nd, and around 2nd of December. The mortalities, as I've said, the first one was died at reception. These 2 did self-medication, and we lost them at the community level. But this one reported to the health facility. She had comorbidities, and while being managed, we lost her. That is to just show where the cases were. You can see there is, on the spot map, there is a scattering and cases coming together at one point in time. And this is the area that had problems. And we noted from what we were doing in terms of investigation that the area has very high population. It is actually an urban informal settlement. It has inadequate space for wash facilities. And being an island, of course, definitely it has sandy soil with poor drainage. There was a lot of splash floods when it rains around that particular area. We were keen on WASH, that is water, sanitation, and hygiene. We noted there was erratic supply of drinking water from the main supplier, who was the Lamu Water and Sewerage Company. Following the pump that was supposed to pump the water was not longer working, and the community turned to the available water sources locally, including wells, including boreholes and taps that we have within the community. And you can see 98% of those cases assessed water from the local available water. In terms of water treatment, 5 days before onset of clinical presentation was very low, as low as 91.2% of those accessing well water did not treat at all. And again, 92.9% of those accessing from boreholes and available taps also did not treat their water. Then again, on household sanitation, although we had good coverage in terms of availability of toilets and latrines, we noted that they were very close to the available, the wells were closer to the sanitation facilities that were available. And you can see from the graph that almost 78.7% of the sanitary facilities were in very close proximity to toilets, 1 to 10 meters apart. Then in terms of laboratory and environmental investigation, we wait for the meteorological records. There was very close association between the occurrence of cases in relation to rainfall. We had three high peaks of rainfall, one coming very early in October and two coming early in November, which might have really contributed to the outbreak. So in terms of stool samples, we had 17, febrile chloride testing positive for 10, water samples 92.9% for coliforms and 85.7% for Escherichia coli. So as I wind up, the exposure factors were water shortage that led to use of water from the available sources, high rainfall, close proximity between the water sources to sanitary facilities, contaminated water facilities, water sources that expose the community, consumption and use of untreated water, and poor health-seeking behavior, as well as inadequate IPC within the community. So we had interventions within the outbreak period, including water treatment, also disinfection, management, laboratory support, risk communication, and we also had long-term. What would have happened to prevent this in the future? We recommended for adherence to public health requirements in planning and construction, adoption of pit liners, among others as shown, including the necessity for cholera vaccination. So in conclusion, the presence of fecal coliforms shows water contamination, and previous cases in Kenya have not been associated at all with groundwater contamination. There were gaps in healthcare, including poor health-seeking behavior, and we strongly recommended for health-seeking behavior change, adherence to public health requirements, including construction of sanitary facilities, IPC, and water sanitation practices. And through all this, then we will be able to prevent transmission of fecal pathogens to humans and the environment. Thank you.
Speaker is Bakalilu. Yes. Okay, Kijera.
Good morning. Good. Thank you very much for the introduction. I am Bakalilu Kijera from the Gambia, Minister of Health, Expanded Program on Immunization. Here to present on measles outbreak investigation in North Bank East and Central River region of the Gambia. This is going to be the presentation on Ireland. I will introduce the topic. I'll talk about the methods that we use. I will discuss and give a good recommendation. Measles is one of the most contagious human infection, but the beauty is it is a vaccine-preventable disease. On January 31st, 2023, measles outbreak was declared in North Bank East and Central River region of the Gambia. So we form an outbreak response team, and this includes laboratory technicians, epidemiologists, communication officers, and equally the public health officers in the regions concerned. What was our aim is to determine the cause of the outbreak. We want to know the cause of the outbreak, the magnitude of the measles outbreak, and equally to implement public and then preventive and control measures. The Gambia has a population of 2.4 million. It is surrounded by Senegal, except one side, that is Atlantic Ocean. You're going to leave the Gambia without passing to Senegal, or you choose the ocean. And then the outbreak was in two regions, as shown in the map, that is Central River region and North Bank East region. We've conducted a descriptive cross-sectional study and equally developed an outbreak case definition. As any person under 15 years with a fever and macular papular rash in the North Bank East and Central River region from December 28, 2022. The methods that we use, we've conducted active case search and also contact tracing in communities where cases were coming from. We reviewed whole facility records and also did some environmental assessment, especially in schools where some cases were coming from. We equally collected specimens from those that were having the symptoms. And of course, we managed cases during the investigation and response. We equally vaccinated people who were contacts as well as part of an intervention in order to control the outbreak. This map is the outbreak region, and that is North Bank East region and Central River region. The index case lives just a few meters from Kaolack. Kaolack is a region in Senegal. And most of the cases in North Bank East region are around this end, where we have school there as well. More than half of the cases, almost 59%, were from Central River region. And then the positivity rate was 14%, and there was no death. Of the 121 suspected cases, 14% were confirmed measles IgM positive. Nearly 3/4 of the cases from the table, 70%, were children more than 5 years. And nearly 59%, more than half, were female, and equally, 59% almost were not vaccinated, did not receive a single dose of measles. This is an epic of the onset of measles IgM positive from January to June in the affected region, and that is North Bank East and Central River region. The outbreak was declared 31st January 2023, and in the next day, that was on the 1st, investigations and response begins. The last case was detected 18th May, and then the outbreak was declared over on the 19th June after 2 incubation period of the last case. This graph shows the measles rubella 1 and 2 vaccination coverage in the affected region in the past 4 years, from 2019 to 2022 in North Bank East and Central River region. Overall, MR2 coverage did not reach our target, and that is 95, except for CRR in 2022. We've been doing good as far as MR1 is concerned, but MR2, which is given in the second year of life, we have some challenges there. There was also supplementary immunization activity, SIA, across the country in October 2022 and also in May 2023. These 2 regions, North Bank East region recorded 101% coverage, and Central River region recorded 93%. As part of the response, when we went to the communities, we also took it as an advantage to vaccinate the contacts. We vaccinated 49 individuals and collected 3 specimens from the affected or from those who were having the symptoms of measles. Let's discuss. We said more than half of these cases were children that were 5 years and above, but this is not in conformity of what was observed in Senegal, our neighbors. The reason could have been probably because there was this immunity gap between children that were 5 to 10 years. That could be the reasons why the disparity happens. And equally, majority of the cases were not vaccinated, and this is also in conformity with a study that was conducted in Senegal. Senegal and Gambia were neighbors, and during the time of this outbreak, there was cross-contamination of measles in Senegal. And then there is this free movement from Gambia to Senegal and from Senegal to Gambia, so the borders are very porous. Let's conclude. We said Kaolack, which is a region in Senegal, was the source of this measles outbreak. And then the outbreak was caused as a result of immunity gap for children that were between 5 years to 10 years. And of course, cases were more than 5 years. We recommend that Ministry of Health should enhance cross-border coordination between Gambia and Senegal, sharing of information, responding to an outbreak together, and also to make sure that in the border regions, surveillance is very sensitive. We equally recommend that the expanded program on immunization should conduct supplementary immunization activity, not only for the under 5s, because we are seeing cases of above 5, that is from 5 to 10 years. So we recommend to them to do a supplementary immunization activity for the cohort where there is immunity gap. I acknowledge Minister of Health, the Gambia, for their support during the response phase, and equally acknowledge Ghana Field Epidemiology and Laboratory Training Program for training for my program. And equally, EDCTP, European and Developing Countries Clinical Trial Partnership, for sponsoring my program. I thank you all for listening.
Kalilu. The next speaker is Aladayo on Mpox.
Thank you very much, the chairman of this section. Good morning, everyone. I am Oladayo Awoyale, a graduate of the Nigerian Field Epidemiology Training Program, and I work with the Kwara State Ministry of Health. So this morning, I'll be presenting to us the symptomatology of Mpox in Kwara State, North Central Nigeria. Is absence of fever enough to rule out Mpox? And I'll be using this outline. Mpox, formerly known as monkeypox, is a zoonotic viral disease caused by the Mpox virus. And the first human case was recorded in 1970 in the Democratic Republic of Congo. Nigeria had a large outbreak in 2022 with a case fatality rate of 1.5%. And this year, August 2024, the African Center for Disease Control and the World Health Organization declared Mpox a public health of emergency of continental security and public health emergency of international concern, respectively. So this is the history of Mpox in Nigeria. The first outbreak of Mpox in Nigeria was in 1971. We had one case, and in 1978, we had another outbreak. But interestingly, for over 39 years, no case of Mpox was recorded in Nigeria until 2017, when there was a resurgence, and we had 88 cases. And since then, we've been having outbreak yearly. And the largest we have recorded was the one in 2022 with 762 cases. So in Kwara State, a north central state in Nigeria, the first outbreak of Mpox was in 2022. 21 confirmed cases were recorded, and since then we have not had any case of Mpox in Kwara State. So we set out to describe the symptoms of Mpox in Kwara State, and we also try to determine if the absence of fever is enough to rule out Mpox. So what method did we use? We investigated all the Mpox cases in Kwara State in 2022, and we used the Nigerian Center for Disease Control case definition. These data were extracted from patient case notes and summaries, and we analyzed using frequency table, bivariate and multivariate analysis. We also use logistic regression to determine if the absence of fever can predict the absence of Mpox. So our case definition, a suspected case is an acute illness with fever greater than 38.3 degrees, intense headache, lymphadenopathy, back pain, myalgia, asthenia, followed by rash. And a confirmed case is a case that is confirmed in the laboratory. So we had a total of 64 confirmed cases of Mpox in 2022. So out of these, 21 tested positive. And out of the 21 that tested positive, 62% of them were females, and 52% of them were less than 18 years of age. The symptoms they presented with were muscle pain, fatigue, fever, headache, and rash. And fever, which is a symptom of interest in this study, among the individuals that tested positive was 67%. But interestingly, even among those who tested negative, 91% of them also had fever. So we proceeded to use logistic regression to determine if the absence of fever can predict the absence of Mpox. And we found that among individuals that had fever, the odds of having Mpox is 80% less than in those without fever. This is interesting. So we concluded that the absence of fever is not enough to rule out Mpox. And we recommend that there should be a high index of suspicion among exposed individuals, whether with or without fever, especially if they have the other symptoms. I want to acknowledge the University of Ibadan, EDCTP, Kwara State Ministry of Health, ICR, and Warwick University, and African CDC. Thank you.
Okay, thank you very much. So we have Ali, who is not here, and we have some time for more question and answer. For those who want to ask some question, please come to the microphone. Before that, I have a couple of questions to the first presenter. Can you describe the link between the water sanitation and the outbreak? And the second presentation, measles, very interesting results. You have a kind of discrepancy. You have tested about 120 people, and you have 14% positivity with IgM. Can you make some comments about this discrepancy in clinical suspected cases and the IgM testing? And the Mpox, very interesting to see that Mpox has been around in Nigeria for years. And I want to know the cases you have, whether you see any clustering around the index cases, if you can comment on that. Thank you.
Thank you for the question. How does water sanitation and hygiene link to the outbreak? So from the investigation that we did, we noted initially erratic supply of water. The community went without water. We were keen to look at where they are getting their water for the time that they have not had water. we had primary and secondary water sources, which we looked at, but a majority of the primary water sources pointed at wells that were within the settlement. It pointed at taps, and these taps could either be from a borehole or a well. There are some wells that were closed, and they were using pumps to pump water from that well. So that was the point of interest. We picked samples and tested them, and the samples were actually positive. Out of the total number of 26 samples, 26 tested positive for coliforms, and we had 24 that tested positive for E. coli, which showed fecal contamination. We were interested to go back and look at what is this that could be contaminating different water sources that are not located in the same area. And we were very keen to look at the proximity or between the water sources that the community was using to get their water and the available sanitary facilities. We noted there was very close proximity, even within one homestead where there was a bit of distance between their own well and their own sanitation facility. Then from the neighboring side, there was a facility that was closer to the well. And therefore, we felt that there was a link. We are talking about an island that has sand soil. We are talking about high rainfall that is raising the water table. And therefore, there was high possibility of an aqueous flow and connection between the high water table within the sanitary facilities and the high water table within the wells. And therefore, that contamination could have really happened through that channel. And again, we know sand soil is highly permeable. There is less resistance and filtration effect, and there is a possibility that the microbes found their way into the wells that were in close proximity. Thank you.
Okay, thank you very much for that question. Basically, the 120 or so, these were also tested. They were all suspects, and that were tested, and then 17 of them were confirmed measles IgM positive, if I get your question right. Thank you.
Okay, please. May I beg that you repeat the question, sir?
The incidence of cases around the index, have you investigated?
The index case?
Yes, around the index cases.
States in 2022? Yes, it was investigated, sir. Okay, so this particular study, we set out to study the symptoms of Mpox in Kwara State, and particularly we were interested in fever. Wanted to know if the absence of fever is enough to say someone does not have Mpox, because it's a major symptom in the case definition being used to identify cases. So that was what we set out to do. So, but the first case was investigated. If there is any particular variable or of interest about the first case, I will be willing to share.
So myself, Dr. Morgan, India FETP. So congratulations to the presenters. So my question is to the presenter on measles epidemiology investigation. So my question is, your investigation report showed 58% of the cases were unvaccinated, and you have given the recommendation based on that over 50% were unvaccinated over 5 years of age. But my question is, the 58% denominator is among the cases. Ideally, maybe my other words I will try to put is, have you tried to attempt to calculate any relative risk or odds ratio where you would found the risk of having infection among unvaccinated is more than vaccinated, because the recommendation is purely based on descriptive? How do you want to defend?
Thank you very much for that wonderful question. I love it, actually. The presentation is basically more of descriptive. I've not gone further to do analytical. But you realize that in vaccination, 85% do seroconvert, and then 15% do not seroconvert, meaning if you get the vaccine, you have 85% chances that you will not get the measles virus, also measles infection. So this is one of the limitations of the study, that this study we could have gone further in order to do some or ratio, some association between unvaccinated and then vaccinated. But by looking at the figure, obviously, you will know that it will be statistically significant, though it is not in this published slides. But perhaps we can have that discussion after this session. Thank you very much.
Yeah, thank you.
Hello, congratulations to all the presenters. I'm Mahamoudou Touré from University Clinical Research Center of the University of Bamako, Mali. So my question is for the Mpox presenter. So my question is about the fever, the absence of fever and the presence of the fever, because as you know, fever management mostly is done at household level. So I want to know how you get to know who has had fever or not, and when and how fever was measured to define the case with or without fever. Thank you.
Okay, thank you very much for that question. So all the suspected cases, their temperature were measured at presentation, and those who have temperature that is higher than 38.3 degrees centigrade, as is being used in the case definition, were identified as suspected case. So you rightly said that majority of fever cases are managed at the home level, but for disease surveillance, we still use fever as an entry point for Mpox and many other infectious diseases. So it is also important for us to identify if it is enough to rule out some of these diseases when there is no fever. Because if we continue to do that, we will be missing a lot of cases. And being an infectious disease, they will go back there and be spreading, infecting others. So that was how the fever was measured, and then we now determined if someone who does not have fever, if it is enough to say that the person is not a suspected case. Thank you.
Okay, thank you.
Yeah, thank you, Naomi Luke from CDC Kenya. So again, like everybody said, very good presentations. Back to Mpox again. So one of my questions was asked about the fever, and I'm so happy to hear you say that absence of fever does not rule out somebody. So that's something we've done in our studies, and we've proven that fever is just, we all know malaria, chickenpox and all others have fever. So I was very happy to see that conclusion. I was a little worried at the beginning. I thought, is he going to say the other way around? So that's good. So going to symptomology of Mpox, I'm just wondering, you might not have the answer to this one, but is Nigeria looking at chickenpox? So we are realizing in Kenya that we do have Mpox sort of outbreak right now, and we are doing a differential with chickenpox. And 60% of the people presenting with fever and or the other monkeypox looking like, symptoms are chickenpox. Has Nigeria looked at that in any way? Thank you.
Okay, once again, thank you very much. I will not want to take that as a question, but rather a comment and a take-home. But in Nigeria, we consider chickenpox also, because the symptoms are quite similar. In fact, interestingly, there are a lot of rashes that can be mistaken for one another. So it is just good that when you are investigating a case of rash, you should think very broadly and look at a number of situations that can cause that. So thank you very much once again for that comment.
Hi, my name is Kalia Ackerman from Macquarie University in Australia. And like everyone else has said, thank you for some really fantastic presentations. My question is for Mark Medika. So given that you gave, in your introduction information, you said that the outbreak was on an island which was surrounded by regions that weren't affected by the large outbreak. And I was wondering if you think that it was actually linked to the big outbreak that you mentioned that was over a year, and if so, how it was linked.
Thank you for the question. It was a unique outbreak, and probably before even investigating what happened in the island, which is Lamu County in Kenya, we had outbreak elsewhere in the country, but it was not anywhere around Lamu. It was not, Lamu actually has part of it being the mainland and part of it being an island. We have quite a number of islands that are adding up to Lamu County. This particular island that actually contributed to a majority of the cases is totally isolated. There's no link between that island and the mainland. When we were going there, we had actually about our airline from the other side and pick a motorboat all the way to the island. So there was actually no correlation between what is happening on the other side and what is happening there. And in the map that I showed, how we have mapped Kenya in terms of risk of cholera, actually Lamu County on its own is surrounded by counties with a very high burden of cholera. But at that point in time, they didn't have cases at all. It was actually a unique appearance for Lamu County, which actually for a decade had not reported cases, and being isolated is showing cases for us to go and investigate and find what could be the issue. So that was why we had to go to the island and do further investigations. Thank you.
Thank you all the presenters. My name is Kafelo Adisalena again from Curtin University, Australia, Senior Research Fellow. My question is going to the last presenter, Ola Diao. It's really interesting to know more about mpox, and I would like to ask about the characteristics of fever and the timing when you measure the fever might determine to say there is high fever or not fever. And would you give us more information about the characteristics of the fevers as well as the timing of the measurement, and also what are the pathophysiological conditions for the patient to develop fever or not develop to fever, and is there any characteristics like demographic characteristics for the cases to have fever and not to have fever? Thank you.
Okay, thank you once again for that comment. We did not characterize as either high or moderate or low fever. We were guided by the case definition. And in the case definition, we use a temperature that is higher than 38.3 degrees centigrade. So for mpox, so because of this, we classify those who have body temperature greater than 38.3 degrees centigrade as those who have fever. And those who have below are the individuals without fever. But again, why is this an interest? Because we all know that fever is quite important in disease surveillance. For a number of priority diseases, fever is there. But again, a lot of people would have tried a number of things before coming to to report. So it is possible that because of the indiscriminate use of analgesics, some people may not be having fever. But again, if we are ruling out these infectious diseases like mpox because of that, we will be missing cases, and they will continue to spread the disease. So they were measured, the temperatures were measured at presentation. Thank you.
Thank you to all the presenters. My name is Lilian Muchai from the University of Witwatersrand. My question is to the second presenter. Did you explore other factors that may have resulted to the outbreak, such as cold chain maintenance, vaccine administration? Were those explored apart from just the people who are vaccinated? Thank you.
All right, thank you very much for that question. Yes, we also measure other factors, though It is not analytical, like I said, so because in order to say this is that, you have to do some association to conclude that. But during our investigation, we also took issues also into consideration, like environmental assessment. During my presentation, I did mention that cases were also coming from schools. So that school is a boarding school. So you understand that the place is not well ventilated, the place is overcrowded, so the chances of transmission of the measles virus was very high. So there was an environmental issue. So going to vaccination, cold chain management, and other factors, I work with the expanded program on immunization, and then recently we have fund for Japanese grant. The country has no issue as far as cold chain is concerned. All the facilities are well equipped, and then the vaccine delivery also, there is access as far as vaccination delivery is concerned. So the only issue that we registered last time, because back in 2022, there was an outbreak of AKI, acute kidney injury in the Gambia. Maybe most of you must have heard about it. This was as a result of consumption of some oral syrups, paracetamol suspension, and then promethazine syrup. So you understand that during that time, the trust that the population have for Ministry of Health, to be specific, was very low. So that one, during that time, the vaccination coverage reduces, and then even the SIA, if you can see in the slide, we conducted in October 2022, and also in May 2023. The May 2023 was a follow-up because of the poor coverage in October 2022, all as a result of AKI. So to answer your question, we'll say that there was no vaccination cold chain issue, but there was, of course, an environmental concern, and like the vaccination uptake also was very low. I hope I answered your question. Thank you.
Thanks to all the presenters for the really interesting presentations. I'm Marcus Gansel. I'm from the University of Alberta in Canada. I just had a question relating to, or a question for Mark relating to the presentation on cholera in Kenya. You mentioned briefly during the background of your presentation that cholera outbreaks tend to occur in Kenya once every 5 to 7 years or so. Are there like epidemiological characteristics of cholera that tend to like cause that cycle or relate to that cycling? Or is that just sort of an incidental thing that you happen to see outbreaks once every 5 to 7 years?
Yeah, thank you. Thank you. The epidemiology of cholera in Kenya is a bit well defined. I talked about reoccurrence of outbreaks in every 5 to 7 years. Actually, we still odd that even within the outbreaks themselves, they take a bit of time to clear. The circumstances around which cholera happens in Kenya, and that are totally different from what was our finding from the investigation, is that cholera in Kenya has been associated with the urban settlement that is informal at some point, and this is to do with either insufficient sanitary facilities and again inadequacy of water. And we experience this more when we are coming from a drought towards the rain season. The community is relying on water sources from unclean water sources for their consumption as well as other uses, and it has actually been happening. But the scenarios in Kenya are totally different. We have the urban side, we have the local community end, and we also have the refugee camps. Now, for the refugee camps, it is totally different. We are talking about a high-density populated camp. We are talking about the ratio of the refugees to the number of available facilities. We are talking about uncontrolled entry from surrounding countries, and therefore the scenarios vary depending on the particular situation that we are in. But clearly, cholera in Kenya has been associated with poor hygiene, sanitation and hygiene in a majority of the cases, other than the refugee camps we have in part of the country. Thank you.
Thank you.
Thank you very much. Thank you, my co-moderator, Alex, and all the presenters and the audience. I think we enjoy a very great series of presentations, and a good insight from what the field epidemiologists are doing in Africa. From the dengue to diphtheria in the prison, and anthrax in animal and human, and the groundwater contamination and cholera, to measles and mpox, the new disease of interest. And so, and everybody enjoy what you have presented, and we can continue the discussion after this session. Thank you very much for your attention.